echocardiography. So when we are asked to do the quantitative assessment of left ventricular systolic function, the first test all over the world is now the modified Simpson method of assessment of left ventricular systolic function. Although in our day-to-day practice, we are still practicing the Tico's method. First of all, we need to adjust our machine. The depth should be reduced. We should try to use transducer of highest frequency, which is possible for particular patients. And again, we know the choice of transducer is dependent upon the body habitus of the patient. If the patient is lean and thin, then we can really be able to use a relatively higher frequency of transducer. And next to depth and the choice of transducer, we need to adjust the frame rate for this patient. And gain control is, of course, important. Particularly in this patient, we need to see the trabeculae. And if we are able to see the trabeculae well, then probably with reasonable gain, then this will do the trick for us. And our next job is to define the endocardial border, which should not include the trabeculae. The principle of Simpson method uses the disc method. Here we can see that there are many horizontal lines and one longitudinal line. Actually, each horizontal line is, if we assume this as a three-dimensional mode, because this is two chamber view, and we had the 4-chamber view. Together, they make a three-dimensional assumption, just like a piece of bread. And we are going to estimate the volume of each piece of this bread and then add it to the whole volume of left ventricular systole and left ventricular diastole. And as we know, the computer calculates the ejection fraction from left ventricular end diastolic volume and left ventricular end systolic volume. And we know by definition, ejection fraction is the fraction of blood that is ejected into the aorta during systole. So it should be stroke volume divided by left ventricular end diastolic volume, which means that left ventricular end diastolic volume minus left ventricular end systolic volume divided by left ventricular end systolic volume. So we need to estimate two volumes, the left ventricular end systolic volume and the left ventricular end diastolic volume. Here in diastole and in systole, we measured the volume by dividing the left ventricular cavity into 20 small volume, as I said, analog to the piece of bread. So when we add all these 20 pieces, then we get the left ventricular volume, and the computer is good at doing the mathematics, and they give us the ejection fraction. The crucial job in assessing the left ventricular function by Simpson method is to defining the endocardial border. মার্কারটা কিভাবে ইউজ করে? পয়েন্টারটা ইউজ কর।
মার্কার তোমার স্মার্টফোনে বোধহয় পারা যাবে না।
স্মার্টফোন না স্যার, এটা ট্যাব স্যার।
ও ট্যাবে তো পারবা, তুমি ওই যে কি বলে মাউস দিয়ে ই করতে পারো, দেখাইতে পারো। আমার মনে হয় দেখা যাবে না।
মাউস স্যার ওই যে একটা অপশন থাকবে আর কি ওখানে মার্কিং ইয়ের, তো হাত দিয়ে টাচ করলেই আসবে।
পেন যেটা সেটা?
জি জি জি, পেন জি। হচ্ছে তো, এখন মনে মার্কিং হচ্ছে।
কোথায়?
একটা দাগ আসলো মনে হয় না।
ও আচ্ছা। কোনটা নিব? এখানে অনেকগুলো জিনিস আছে।
স্যার কালার যেটা বা হচ্ছে
কালারটা লাইন।
স্যার ওই লেজার পয়েন্টার আছে কিনা দেখেন স্যার, লেজার
হ্যাঁ লেজার পয়েন্টার থাকার কথা লাল
লেজার
কালারের।
পয়েন্টার থাকলে স্যার ওইটা ইউজ করেন।
স্পটলাইট আছে?
হ্যাঁ হ্যাঁ জি এটাই নেন, এটাই নেন।
স্যার মার্কারটা আপনার স্ক্রিনের বাইরে স্যার।
এই যে এটা।
এই যে এখন চলে আসছে, জি ওকে।
Thank you. So we start at the annulus, lateral annulus, and then we try to trace the border. Important point is to identify the okay, I have now pointed it on left ventricular muscle, myocardium. Generally, the myocardium should be visualized between the pericardium and the endocardium. A strip of muscle. The muscle contains the blood, and so it looks black. And this strip of muscle should be visualized between the between the trabeculae and the pericardium. And the trabeculae should not be included within the line. So most of the time, probably we are able to delineate this line, but in 20 to 30% cases, it is difficult, and we should not adopt the symptom method if we don't have the proper delineation of the endocardium. এটা ইসে করতে হবে না মার্কারটা?
স্যার এটাই পয়েন্টার স্যার, এটাই পয়েন্টার।
নেক্সট স্লাইডে মুভ করার উপায় কি? So as we said, our first job is to delineate the inner border, and then automatically the computer make all this assessment of volume and eventually to ejection fraction. But as I said, there are three potential limitation. One is translational motion. Then we talked about the delineation of the endocardial border, and the foreshortening is the important Achilles heel of Achilles tendon. Translation is the motion of the heart that occurs during quiet respiration, and the heart moves from single line. Here we can see during diastole, the cursor is situated in the middle, but during systole, it shifted to the lateral side. So we are not getting the same point of cursor line during diastole and the systole. This is one of the important limitations, especially when the patient is breathing rapidly. Translational motion. And the next important point is the foreshortening. When the transducer is not really placed in the apex, true apex, then we cannot cut the left ventricular slice into proper slicing, and the apex is not being cut, which resulted in the foreshortening. Foreshortening is very important point where we miss the accurate assessment of the left ventricle, and we should always avoid to avoid this foreshortening. And there are certain way we can avoid the foreshortening. These are the steep lateral decubitus position, and we should use the cutout mattress. Every echocardiographic examination table should have a cut point so that the transducer can be placed more laterally, and we can have a steep lateral decubitus position. And at a times we rely on palpable apical impulse, but that should not be the rule. The rule is to find out the maximum dimension of the left ventricle, and to obtain that maximum dimension of the left ventricle, at a times we need steep lateral decubitus position, and to obtain this steep lateral decubitus position, often we need to go beyond the lateral side, and cut matrix is a good solution to that. To minimize the translational motion, we can at a times ask the patient to hold his respiration at the end of the expiration, or we can also ask him to have a quiet respiration. To adjust the imaging, I already have mentioned that there should be minimum depth. Only a part of the left atrium should be visualized. And as I already have mentioned, that highest possible transducer frequency and the frame rate should be more than 30. One of the way we know we should be able to check that whether we are landing in a foreshortening is checking the apical portion of the left ventricle both in 4-chamber and 2-chamber view. In this picture, we can see the apex in the 2-chamber view and apex in the 4-chamber view are not in the same line. Here, the 2-chamber view is inclined to the left, and it's not just pointing along the line of the so the apex in the 2-chamber should have been here in the same line. And when we can put this in the same line, then we are a little bit sure that we are not doing this foreshortening. স্যার প্রথম আজকে কনফারেন্সে
না ঠিক আছে স্যার মিস্টার স্যার ঠিক আছে আপনি কন্টিনিউ করেন স্যার
So I will concentrate on the Simpson method. Basically, Simpson method is the method which is required to quantify. If not all the time, we need to do this Simpson method. But as I said, when in certain situation, when people will expect that you should give the number, and in those cases, you have to minimize the translational zone by having the patient a quiet respiration. We have to optimize the image resolution. In our first lecture we saw, Dr. Firoz has elaborated that very nicely. I was so impressed with that lecture. We have to have the minimum depth. We have to have the highest possible transducer frequency, and the frame rate should be more than 30, and of course the gain should be optimum. To minimize the foreshortening, we really need to have a steep lateral decubitus position, for which the cut out matrix is one of the best solution, and we should always be aware about palpating the apical impulse, because palpable apical impulse should not be always the point where we should place the transducer. We should rather rely on this on the principle of having the apex in both 2-chamber and 4-chamber view in the same line, and we need to have the maximum diameter of the left ventricle, not just relying on the palpable apical impulse. And to delineate the endocardial border, the first thing we need to adjust the machine, as I said, the depth, the transducer, and the gain control and the frame rate. This fourth thing. If still we cannot identify the endocardial border, then the solution is contrast enhancement, which are not doing here at Bangladesh. This is one of the picture. The green picture actually showing the accurate delineation of the inner border. This is a graph was taken from different operator doing the endocardial border lining, and there were so variation in this lining. Some people marked on the pericardium, some have included the trabeculae, and only a few patients could fix the target of proper fixing between the myocardium and the trabeculae. So the mistake is common. I saw a presentation in Singapore in 2004 where one of the renowned echocardiographer was demonstrating the Simpson method of assessing the left ventricular function. It was a normal left ventricular function, but at his first attempt, it showed an ejection fraction of 40. And I was also impressed with Professor Tuhin Haq when he started showing the Simpson method, because I thought that I will never dare to do this in front of the audience, because that experience in 2004 made me so scared about showing any demonstration of left ventricular function by doing the Simpson method, because if you want to show it to someone, you ought to have some mistake. But doing this for repeatedly, and if you can avoid the foreshortening, and if you can properly delineate the endocardial border, then probably you'll be little confident. So this is the picture of contrast enhancement, contrast enhancement of the left ventricle, which can delineate the endocardial border, and the trabeculae is included within this contrast material. This contrast material is available. These are commercially made agents, which is injected through intravenous route, and not that costly. We need this test in a special situation when we cannot see the endocardial border, and we also need to quantify the left ventricular systolic function. These are the situations when we should have this contrast material available. I tried a little bit to procure this contrast material, but I really failed. I will ask my very learned chairman sir to whether we can have this contrast material in Bangladesh, so that for few patients, especially when we do the stress echo test, this contrast tests are needed, because here the endocardial border can be well delineated. And even then, people have shown that with the contrast, you can miss the endocardial border. So it is really difficult to have a good left ventricular quantification of ejection fraction. So I was asked to make things simple. I really tried to confine my discussion on the modified Simpson method of assessing the left ventricular function, because this is the most practiced standard way of producing the left ventricular systolic function. We can see in this picture in our lab in Bangabandhu Sheikh Mujib Medical University, we were a little successful in delineating the inner border. The key point, as I said, that depth should be minimum. The frequency of the transducer should be as high as possible, and we should avoid the foreshortening and the translational zone. Probably this is one of the key of the success. The reason why there are mistakes is if we look at the myocardium, piece of myocardium, the pectineus muscle are horizontal muscle, which are at a times confused with the trabeculae. And at a times trabeculae are thought to be a part of the pectineus muscle. That is why some people make the line in the inner side and some people in the outer side. But this strip of the myocardium will differentiate between the pericardium and the endocardium, so that we can exclude the trabeculae and we can well delineate the inner line. So these are the important things. Let me again recapitulate: the adjustment of the gain, the adjustment of the depth and the transducer. The frame rate should be 30 because we need to have the left ventricular diameter, maximum diameter and the minimum diameter. Although it is conventional to have the measurement in the diastole and the systole by using the ECG gate, but I think it is probably the best idea to have the maximum left ventricular diameter, which should be measured during which should be the point of measurement during diastole, and the minimum diameter of the left ventricle, which should be the measure for systole. So maximum left ventricular frame and the minimum left ventricular frame are the frame that we should take as the surrogate for diastole and the systole. So these are the things that we should practice again and again, so that we will be little confident to show it to other people, as Professor Tuhin Haq did in one conference. There are other methods of assessing the left ventricular function. স্লাইডগুলো মুভ করার কি আরো কোনো উপায় আছে? The most popular and the first method that was introduced was the Tycho's method. In Tycho's method, it is assumed that the left ventricle is elliptical in shape, and in reality, the left ventricle is a real elliptical shape. It was a cine film actually. I failed to show it in the live demonstration, but if you can see the left ventricle in real life, this is again a picture from our echo lab, and we can see how similar both these pictures are. And this is the case in most of the patient when without any regional motion abnormality present to us. Because these are the patients are referred for different reasons, for exclusion of cardiac disease or for some preoperative assessment and the other reason. And if we do not have any regional motion, I don't find any reason why we should not adopt this. Because in this picture, you can see how closely the left ventricular structure resembles the ellipse. And if we can measure this dimension, only one dimension at the base of the left ventricle, and as I said, the machine is very smart in computing the whole mathematics and give you the left ventricular cavity size. And when the patient has got uniform left ventricular motion, be it depressed left ventricular global hyperkinesia or it normal function, I do not find any reason why we should not use this ellipse method, because this is the method we have been using for years together. We are confident, and when we do echocardiography as street echocardiographer, we do not have any choice but to use this method most of the time. So I will still give emphasis on doing this method when we have normal left ventricular function or when we have global hyperkinesia, and in those situations, I think elliptical method can be as good as any other method. If you see historically, the study which have shown the benefit of the drugs, which increases the ejection fraction, the LVOD trial and the LV well heart trial and other trials, all these trials have used this method, and they have stood the time of test of time in saying that this drug are being useful based only on the method of elliptical method of assessment. So many people hate to use this method nowadays, but for practical purpose, I think it is reasonable to use this test, especially when the patient have got the reasonable normal left ventricular function. So in this picture, it is always 2D guided M mode. We need to put our the cursor in a place when we can barely see the chorda tendineae, and it should touch the tip of the anterior mitral leaflet. At a time it touches the tip, at a time it touches the chorda tendineae. And the major point is to put the cursor, which should be perpendicular to the intraventricular septum. And this is the ideal picture again from our laboratory. We can see that we could delineate the inner border and the outer border. Again, with the help of ECG guide, we know the end diastole. We take a measurement at the end diastole from inner endocardium to inner endocardium of the septum and the posterior wall. And the similar thing is being done for systolic measurement. During systolic measurement, the point at a time should not be, at a time when we do not have the ECG, then it should be the bottom point of the it should be the lowestmost portion of the septum, wherever it is the lowest point is, and then we should proceed toward the posterior wall. And when we have the ECG, then the ECG should guide us the end systole. One of the reason people do not really hit the baseline, and they use different level for the intersection. And this is one of the pictures shown by Harvey Feigenbaum. He was demonstrating the way we really cut the left ventricle during mode echocardiography. We all do it. We have been doing this for years together. One of the reasons for this is probably the base of the septum. If we fail to properly delineate the inner border of the base of the septum, which occurs especially when the patient has got sigmoid shaped septum, then we try to avoid the base and we go shift our cursor little towards the apex. In those cases, actually we should measure intraventricular septum in a different measurement. And nowadays, two-dimensional echocardiographic measurements are more preferred than M mode in measuring different dimension of left ventricle. So we can measure the intraventricular septum separately, but we should put the cursor at the base to have the reproducible result of ejection fraction when we use this M mode method. So these are the different method of echocardiographic assessment of the left ventricle. Some method we occasionally use, especially when we are confused. We are not really sure the amount of number that we are putting as ejection fraction is accurate or not, especially when we have poor echo window and we cannot use the Simpson method. Then we probably try to use different method, 1, 2, 3, or 4 method. If all these methods have an agreement which shows near similar result, then we are a little confident about putting some semi-quantitative assessment of the left ventricular function. Of all these measures, the eyeballing in two-dimensional echocardiography is one of the important method, where we know that when there are 16 segments of left ventricle, and if we have normal motion, then we give 4 points to that segment, and thus the total 64 ejection fraction comes out from those eyeballing. But it is through our experience we know that what is going to be the ejection fraction, and eyeballing is probably the so far for day-to-day practice is the best method. And if we have good endocardial border, then Simpson method will give us probably even better result. But in other cases, when we have normal left ventricular wall motion or global hypokinesia, then probably we can still use the TICOS method. But I would like to see some other method which can really cross-check the measure we have obtained from eyeballing or from Simpson method. We at the times when the patient has got wall motion abnormality, as a cardiologist, we have to face all these wall motion abnormality cases because these are rather our point of interest. And in those cases, probably one of the method, Doppler or tissue Doppler method, and if available 3D echocardiography, we can recheck whether our measures of ejection fraction is near accurate or not. I could not show the cine film. Bullet method still being prescribed in bullet. In this area length method, also known as bullet method. And as I have shown you, the left ventricle is almost, inner cavity of the left ventricle is almost a bullet shape. So assuming the patient is having a normal left ventricular function, then we can measure the cross-sectional area during the diastole and the systole, and again the left ventricular dimension in the length in the longitudinal axis during systole and diastole. If we have both this cross-section and the longitudinal dimension during both systole and diastole, we have software in the computer. The computer calculates the ejection fraction. When we do not have good visualization of the endocardium, but we have got good visualization of the endocardium in the short axis view at the level of papillary muscle, then probably we can use this method, especially when the patient do not have any regional motion abnormality. This is one of the popular methods that is being used by the anesthetics in the anesthetic suits, because they need to measure the cardiac output. And here in this method, this is a method, Doppler method of estimation of stroke volume. And by multiplying the heart rate, we get the cardiac output. This is the method of rechecking if the patient has got good systolic function, good stroke volume. It should be taken as the surrogate marker for good left ventricular systolic function, that is the ejection fraction. Here in this picture, we obtain an this is actually 4-chamber view. I'm not really sure whether you can see it. We should put the sample volume just 1 centimeter below the aortic valve, and the cursor should be in alignment with the septum, and we should be able to obtain a good envelope of the pulse wave Doppler, and then we mark the envelope. We should try to avoid the floppy portion. At a times it is being referred as chin and the beard, and we should not include the beard like this one. The complete envelope should be taken. The another way of knowing the peak is probably the point where this line and this line crosses. That should be the peak point, and we should be able to delineate this point. After delineating this point, the computer automatically gives us the ventricular time integral, and it should be between 16. It should be between 16 and 20. If it is between 14 to 16, we know that there can be mild left ventricular systolic function. And if it is even much lower than that, say 10 or 11 or 8, then we know that the left ventricle is not that smart, not that happy. And to obtain the stroke volume, we measured the left ventricular outflow tract dimension, the same point where we had placed this sample volume in 4th chamber. We try to put try to obtain the measurement from the same point where in 4th chamber we placed our sample volume from inner to inner. And to obtain this diameter, we need to magnify the left ventricular outflow tract, because little error in the measurement of this dimension will give a gross dearrangement in the measurement of the stroke volume. Stroke volume is is derived from pi r square into VTI. We have obtained VTI by simply by outlining the left ventricular outflow tract spectral display. This is the spectral display when we put our pulse wave Doppler in the left ventricular outflow tract, and the machine display this spectral display. If we outline this, the margin of this display, the machine automatically gives us the left ventricular time integral. And if we have the dimension of the left ventricular outflow tract, it will also give us the radius of the left ventricular outflow tract. And by using the formula pi r square into VTI, we'll able to get the stroke volume. So through the Doppler, we can measure the cardiac output and the stroke volume, which is a surrogate marker for left ventricular systolic function. At a time, we are not really sure whether we will give a result of 30 ejection fraction or 40 ejection fraction. Then probably this can give you a confidence by cross-checking that probably you are near to normal, if not normal.
Professor Meshkat, আমার মনে হয় যে আমরা একটু বোধহয় এই 1 ঘন্টা মতো ক্রস করে আসছি। Can you make your conclusion?
আমি কি স্যার 3-4 মিনিট নিব স্যার?
Yes, okay, yeah, sure.
This is the tissue Doppler method where we can see the S wave. The pointer is at the tip of the S wave, S prime. This is similar to that of TAPC in the right ventricle. This is known as MAPC. We can have a quick look on this MAPC to be sure about whether our result is near to accurate. This is MAPC. From MAPC, we can also use the formula to obtain the ejection fraction. On the top, you can see the formula. If you have the tissue Doppler facilities in your machine, and you can use the tissue Doppler to delineate the portion of the MAPC. This is S prime from the tissue Doppler. These are the methods also can give you the cross-check about the measure that you have taken from other standard method. This is E-point septal separation. Mojumdar sir has instructed me to show this point. And also from this E-point septal separation, we can make an estimation of the ejection fraction by using that formula. This is really quite useful when the patient has got reduced LV function. This formula will give you almost near semi-quantitative measures by simply using the E-point septal separation. This is M-mode graph of the M-mode graph of the mitral anterior leaflet. The proximate portion of the topmost portion of the M-mode display and its distance from the septum will give us the E-point septal separation. And it should be less than 8. And more the separation line, the less the left ventricular ejection fraction. And finally, the gold standard for left ventricular ejection fraction measurement is 3-dimensional echocardiography, where we obtain a 4-chamber view after switching it off to a 3-dimensional mode, and automatically there is there are picture of left ventricular. Sorry. ট্যাবে স্যার অনেক সমস্যা, স্লাইডই করে না। 2D strain is another method of estimation. Probably we should not take any attempt of showing you the 2D strain, but little bit of the 3-dimensional echocardiography, because relatively simple. If we have the 4-chamber view, and if we switch on the button of 3-dimensional echocardiography, then this picture comes. Thereafter, we get a picture of 4-chamber, 2-chamber, and apical long axis view. Only thing we need to do is to mark the apex and the base, just like this. Roughly, I'm showing, and the computer will automatically give you the ejection fraction. This is based on the artificial intelligence memory. The machine has got the memory of several measurements. So by using all this simple 3 measurement, it gives you the ejection fraction. And it is said to be the gold standard, although it has got some pitfall. And here actually I want to end up my talk. The concluding message from my side is that if we have no regional motion abnormality, TICO's method is good enough. But when we have to have some quantitative assessment, then probably we should try to go for Simpson method. And while we are doing the Simpson method or the TICO's method, we can cross-check it by doing some very rapid other method. So by integrating the echocardiograph is a beautiful method because it has got its intrinsic method of checking itself. By checking M-mode by 2D, or by checking 2D by 3D, or by all these modalities by Doppler method, if we get a constant result, then we'll be confident about putting some report on left ventricular ejection. Sir.
Thank you, sir. Thank you, Professor Chaudhary Mishkat Ahmed, sir. Ladies and gentlemen, I think we should move to our next topic because we are running short of time.
না, আমার মনে হয় কি ফিরোজ
স্যার,
আপনার 10 মিনিট একটু আলোচনা করি, এটা তো ইম্পর্টেন্ট এলবি। এবং I must thank Professor Chaudhary Mishkat. He presented the thing very understandable. What I understand from his presentation, it is very understandable for the learners also. He make it very easy. Though he is a very tough person to present. Usually his presentation is very tough, but due to my persuasion, he presented it very understandable way. Thank you very much, Chaudhary Mishkat. One point: do you think that the modified Simpson we should measure in both the 2-chamber view only, or both the 4-chamber and 2-chamber view in both this?
Sir, both this method is being prescribed in the textbook. The 1-plane modified Simpson method and the 2-plane modified Simpson method. but we should always try to have the two plane measures.
Practical purpose.
For practical purpose, sir, we should try to use the both plane, especially when we actually do the Simpson method when it is needed. When we expect that, when we think that the person who has referred the case, he is expecting a more or less accurate result. In those cases, we have to give some time, and we should have both planes, sir. Because
if you allow me, I will.
Got
sure.
abnormality, then probably we'll miss something in single plane.
Any question from the juniors? Any question from the very...
Sir, in fact, there is no one question in the question box. That was role of eyeballing in estimation of DLV ejection fraction, which already Professor Mishkat Ahmed sir mentioned in his lecture. Now, Dr. Nur Alam, you have got a question? Or
Yeah. Thank you, Firoz bhai. Thank you, Mishkat sir, for your very brilliant presentation. Actually, I want to ask a very simple question. Day to day, we are doing echo, and in LV function measuring, we have to report it. But in our hand, you see that there are a lot of recommendations from the different groups, like American Echocardiographic Group, British Echocardiographic Society. They are using different parameters. So, what is your recommendation in our clinical practice? How will you calculate, or how will you do a report mentioning the mild, moderate, severe LV systolic dysfunction? What is the ejection fractional digital parameter to quantify mild, moderate, or severe?
Yes, there are difference in pointing out the mild, moderate, and severe. I personally use the mark 40 as 40 to 50 as mild, 30 to 40 as moderate, and anything below 30 is severe. Some people put the demarcation between mild and moderate is at 45% ejection fraction.
Thank you, sir.
Recommendation that we should actually say mild to moderate, moderate to severe, very severe. Probably this 6 grading is little comfortable than putting any marks.
Yes, there is a question regarding, in case of septal dyskinesia, how will we calculate ejection fraction?
Simpson method, 3-dimensional echocardiography, if we have 3-dimensional echocardiography, but we can use the Simpson method, modified Simpson method. That should be used actually, and even then we'll never be able to give the exact measures. There will be error. This is one of the limitation. If we have the dyskinesia and if we have conduction defect abnormalities, this is one of the limitations when we'll never be able to quantify the left ventricular function. But in those cases, we should try to go for Simpson method.
Thank you, sir. We have got Dr. Khaliquzzaman with us. Dr. Khaliquzzaman, have you got any question, comment regarding LV systolic function? Dr. Khaliquzzaman?
No, I have no comment, but rather I should congratulate Professor Chaudhary Mishkat Ahmed for his nice deliberation, making it very much easy for everybody to realize how to measure the LV systolic function. It is one of the important parameter which is very much essential in day-to-day practice. So thanks, Dr. Chaudhary Mishkat sir, for nice presentation. At the same time, thanks the organizers, particularly Professor Abdullah Al-Shafi Muzumdar sir, Dr. Firoz, and Dr. Manoy. Thank you very much.
Thank you, Dr. Khalik bhai. Another question for Mishkat sir is there any role of dP by dt in the assessment of LV function? Or
yes, dP by dt is one of the measures which is being recommended in the textbook to have the measure for left ventricular systolic function. And we can measure it. Our machine has got the software which marks the dP by dt, and it has got role. But to be honest, I have tried this in some of my cases. the correlation is not that strict, not that steep, not that good. Actually, it depends upon so many factors. But
thank you, sir.
It's
Thank you,
relatively.
sir. Dr. Manoharul Islam. Dr. Manohar, do you have got anything to add?
Just I like to add few things. Actually, modified Simpson's method is the most practical one for day-to-day practice. Number one. Number two, it can be in single plane, it can be in biplane, even it can be in triplane. What is single plane? In the single plane, just as Sir has already mentioned, that it can be taken in systole and diastole in apical 4-chamber view, but this is not so accurate. The standard is modified Simpson's biplane method, that is in apical 4th chamber and apical 2-chamber. Even nowadays, for making it more accurate, there is a provision for doing Simpson method in 3 views. One is apical 4th chamber, one is apical 2-chamber, and another one is apical 3-chamber to make it more accurate. So this can be possible. Another comment is that whenever there is marked dyssynchrony, LV dyssynchrony, what should be the ideal way to perform Simpson method? In most of the cases, we may not have ECG gating. In that case, as Meshkat sir had mentioned, that we can take the highest diastolic dimension and the lowest dimension of the cavity as the end systolic dimension. But whenever there is marked dyssynchrony, this golden rule will not act properly. In that case, we have to rely more on the ECG gating. And by seeing the ECG, we can define the end systole and as well as the end diastole. End systole means after the T wave, just end of the T wave, and end diastole means just the beginning of the R wave. So by seeing these two phases, we can perform Simpson method more accurately in presence of marked LV dyssynchrony. Thank you, sir, for your presentation.
Thank you. We'll now move to our second presentation.
Dr. Firoz, there is a question from the audience: how to measure the MAPC? Professor Meshkat, can you tell me? There is a question: how to measure the MAPC?
We put the cursor in the annulus, mitral valve annulus, medial and lateral both in 4-chamber and 2-chamber view, and then the excursion of the mitral annulus is being reflected in terms of millimeter. And if we have all these measures from the medial mitral annulus, lateral mitral annulus in both 4-chamber and 2-chamber view, we have 4 number. And if we make an average of this 4 number, then it gives us the MAPC. And from this MAPC, we have got a formula: MAPC into 4.8 plus 5 is equal to ejection fraction.
Thank you, sir.
Panelists, Professor Tuhin.
Sir, I think we can have the comments at the same time.
Of the panelists after the board presentation.
Yes, sir.
Okay.
Okay. So now we will move to our second lecture, that is evaluation of right ventricular function. May I request Dr. Shahana Jaman to talk on evaluation of RV function. Dr. Shahana Jaman is working as the assistant professor of cardiology in NICVD. She will talk on echocardiographic assessment of the right heart in adults. May I request everyone, please mute your microphone, please. Dr. Shahana, please. Dr. Shahana, unmute yourself.
May I audible to all?
Yes.
Yes. Honorable Chairperson, sir, respected panelists, learned audience, Assalamu alaikum. My today's presentation is echocardiographic assessment of the right heart in adult, a state of the art. Assessment of the cardiac function has largely been focused on left ventricle. The right ventricle, often described as the forgotten ventricle, though it has to pump same amount of the blood.
Shahana, এটা হাত থেকে ছেড়ে দিয়ে কথা বলো, নাইলে তোমার ওই বাতাস গিয়ে ওটাতে লাগে এবং সাউন্ডটা ডিস্টার্ব হয়। এখন কথা বলো। হ্যাঁ।
Assessment of cardiac function has largely been focused on the left ventricle. The large ventricle, despite it has to pump same amount of blood to left ventricle in most of the individuals. Importance of RV as a predictor of prognosis across a range of cardiac conditions has been appreciated.
Dr. Rajiv, please mute everyone other than Dr. Shahana. Dr. Rajiv.
আমি কি আবার শুরু করব?
শুরু করো, আবার শুরু করো।
Assessment of cardiac function has largely been focused on the left ventricle. The right ventricle, often described as the forgotten ventricle, though it has to pump same amount of blood like left ventricle in most of the individual. Importance of RV as a predictor of prognosis across a range of cardiac condition has been appreciated. More effort has been applied to improve the routine assessment of the right ventricle. Echocardiography remains the first line of modality to assess right ventricular structure and function, but there are some limitation of traditional MO two-dimensional Doppler parameter. To overcome this limitation, newer novel measures like 3D, TDI, and strain rate has been established. Now some basics about the right ventricle. It is located behind the lower part of the sternum and anteriorly positioned to left ventricle. It has a smooth walled inlet, a trabeculated apical part, and outlet. Its muscle is about 1/6 of the left ventricle. It pumps blood against approximately 1/6 of the resistance to left ventricle. RV accustomed to low pulmonary resistance and low afterload, hence RV enlargement occurs in response to chronic pressure and or volume overload. Now, what are the problem with RV imaging? It is a structurally complex cavity, fits no simple geometric figure, unusual shape like concentric or triangular. It is irregular endocardial surface, pronounced apical trabeculation, as it located behind the sternum, which limits echo image quality. But 2D injection fraction is not reliable at all. RV size estimation requires integration of multiple views and qualitative and quantitative assessment. Now, why RV function assessment is important? Because it significantly affects symptoms, exercise capacity, and mortality rates of not only various cardiovascular lesions, but also pulmonary disorders. In 2010, American Society of Echocardiography gave guidelines and standards guidelines for the echocardiographic assessment of right heart in adults. It was revised in 2015 as a part of guideline recommendation for the cardiac chamber quantification by echocardiography in adults. Now, what are the objectives of these guidelines? It briefly review right atrial and right ventricular anatomy, describe the conventional 2D acoustic windows required for optimal evaluation of the right heart, describe the measurement and technique required in the routine and directed echocardiographic studies, identify advantages and disadvantages of the each measurement supported by available literature, explain the clinical and prognostic significance of RA-RV assessment. But there are some limitation of these guidelines. The values proposed are not indexed to body surface area or height. Patient at either extreme may be misclassified as having values outside the reference ranges. It is insufficient for the classification of the abnormal categories into mild, moderate, and severe. Interpreter has to use own judgment in determining the extent of the abnormality observed for any given parameter. These are the possible imaging plane for the right heart assessment. First, we will come to parasternal long axis view, and it is the very nice view for the assessment of the RV enlargement, RV wall thickness, and RV dimension. But it has some caveats like view is highly variable depending on the transducer angulation and rib interspace from which it was obtained. It should not be sole view to evaluate RVOT size. Then parasternal long axis view or RV inflow view is very important view for the assessment of the anterior and inferior wall of the RV, also anterior and the posterior leaflet of the tricuspid valve. It is the only view where we can visualize the posterior leaflet of the tricuspid valve. It is also a good view for the assessment of the eustachian valve, IVC ostium, TRZ, and coronary sinus ostium. We assess RV in the parasternal short axis view at the level of the great vessel, at the level of the mitral valve, and at the level of the papillary muscle. At the level of the great vessel, we assess RVOT, pulmonary valve, pulmonary artery, interatrial septum, tricuspid valve, and tricuspid regurgitation. Parasternal short axis view at the level of the mitral valve and at the level of papillary muscle. In both levels, we assess the lateral, inferior, and anterior wall of the or mid level of the RV, and septal flattening is well appreciated in this view. And crescentic shape RV inlet assessment of RV size. It can here we can initial assess the RV size, but in this view we cannot use this view for the assessment of the RV systolic function. Apical fourth chamber view and RV focused view, we use these two views for the assessment of the RV size, shape, and function. Apical five chamber view, it is the modified view. It is the here the moderated band is best visualized, and we also take the measurement of the TR jet from this view. Apical coronary sinus view to assessment of the coronary sinus non-subcostal view. This view is important for the measurement of the RV wall thickness and also for the ESD and PFO evaluation. This is the subcostal short axis view. Here we use the base of the RV wall, including RV inflow, RV outflow, pulmonary valve, pulmonary artery, RVOT dimension. And Doppler measurement of the infundibulum, pulmonary valve, and pulmonary artery can be well appreciated in this view. It is important to use all available views because each view adds some complementary information for the complete assessment of the right heart. Do not use off-axis view for interpretation. When there are disparities between structures and function in different views, the operating cardiologist must interrogate all information to conclude about the global assessment. Parameters that can be measured for the right heart assessment are RV size, RV systolic and diastolic function, pulmonary artery pressure, pulmonary vascular resistance, 3D volumes, RV strain, and RV strain rate. For RV measurement, we use either apical fourth chamber or apical RV focused view. Here we measure minor axis and major axis. This is the major axis and this is the minor axis, and should be measured one frame before end systole or one frame before valve opening, and it is about 53 into 44 millimeter. For the memorize purpose, we can memorize like 55 into 45. For measurement, every measurement, ECG getting a measurement should be done. If we should not get the measurement with the ECG, measurement should not be accurate. Most of the measurement done in the end systole or end diastole. The end systole is the end of the T and end diastole is the beginning of the QRS complex. Right atrial area, here we also measure this in apical fourth chamber view at the end systole, one from just prior to the tricuspid valve opening by tracing the RA blood tissue interface, excluding the area under the tricuspid annulus. And upper reference length is about 18 centimeters square. RV measurement. Rough estimation of the RV size in comparison to LV. Normal RV size is less than 2/3 of the LV. It is mildly enlarged when it is more than 2/3, but less than same size of the LV. If it is roughly equal to left ventricle, then it is called the moderately enlarged. If it is more than LV and form the apex, we will call it the severely enlarged. RV dimension. For the measurement of the RV dimension, we can take both apical fourth chamber or RV focused view, and we measure this in the 3-point basal, mid, and along the long axis. And the upper reference range is about, this is 41, this is 35, and it is 83 millimeter. RVOT measurement. We measure RVOT in the parasternal long axis and short axis view. It is the proximal and distal. And upper reference range is 33 in case of proximal and 27 in case millimeter in case of distal. RV wall thickness. For the measurement of the RV wall thickness, we take a subcostal view, and any measurement more than 5 millimeter considered to be abnormal, but no criterion has been fixed for the defining an abnormally thin RV wall. This is some cause behind the right ventricular hypertrophy. These are the pulmonary hypertension, infiltrative cardiomyopathy, hypertrophic cardiomyopathy, and in patient with significant LV hypertrophy, even in absence of pulmonary hypertension. Now, what are the causes of the RV wall thickening? The most important cause of the arrhythmogenic right ventricular dysplasia or cardiomyopathy, Ulf syndrome, and RV infarction. The causes behind the RV dysfunctions, important causes behind the RV dysfunction are pulmonary arterial hypertension, pulmonary thromboembolism, secondary to the left heart failure, left-sided valve disease, myocardial infarction with RV involvement, congenital heart disease, ERVD, and other systemic diseases. RV systolic function. All studies should include a measure of the RV systolic function using at least one of the following, like visual estimation, tricuspid annular plane, systolic excursion, fractional area change, DTI, derived tricuspid lateral annular systolic velocity wave, and right ventricular index of myocardial performance. We also call this TI index. Eyeballing in case of right ventricular function is a very beautiful assessment in case of experienced operator. It is important measurement for the experienced operator, but it is not good for the beginner, and it has a high inter-observer variability, which is about 40 to 60%. Then TUFS, it is a very easy method, and we use RV focused view. A mode cursor should be parallel to the lateral tricuspid annulus. We should decrease the gain and ask patient to hold the breath. We increase the speed 75 to 100 millimeter per second. We can use the zoom view for the proper alignment. And excursion, another excursion is it should be ECG guided excursion from the end diastole to peak systole. Just look at this. End diastole, this is the QRS complex, and end systole, it is the end of the T. And abnormal is less than 17 millimeter. RV fractional area change. We should use RV focused apical four-chamber view. It is obtained by tracing the RV in systole in diastole. Here is a mass. ECG guided echo is must. We use diastole and systole and calculate. Most of the newer machine, updated machine calculate this has software to calculate this formula and reflects both longitudinal and radial components of the RV contraction, and normal value is more than 35%. But when we cannot properly delineate the endocardial border, it is tough to measure the fractional area change. And RV fractional area change will correlate with RV ejection fraction by MRI. RV fractional area change found to be independent predictor of heart failure, sudden death, or mortality in studies of patients after pulmonary embolism. Tissue Doppler imaging S prime. Measurement taken at the lateral tricuspid annulus in systole in apical four-chamber view. Basal RV free wall segment and the lateral tricuspid annulus are aligned with Doppler cursor to avoid velocity underestimation. A disadvantage is that it assumes that the function of a single segment represents the function of the entire ventricle, and which is not likely in conditions that include regionality such as RV infarction. We give the tissue Doppler cursor in the lateral tricuspid annulus, and this is the S wave or S prime, and normal value is more than 9.5 centimeter per second. RIMP. RIMP or TI index is a global, denotes the global RV performance. Here we measure different timings like isometric contraction time, isovolumetric relaxation time, ejection time, we measure this both in tissue Doppler or pulse wave Doppler. In pulse wave Doppler, we also we use both apical four-chamber view and RVOT view. Here the pulse wave Doppler and here the TDI. TDI is better here than the pulse wave because it is the single, we can measure the time index in the single frame. Here in case of pulse wave, we have to use in the apical fourth chamber. Here we and RVOT, and it's normal in case of pulse wave is less than 0.43, and in case of TDI it is less than 0.54. RV diastolic function. If we suspect RV dysfunction, RV diastolic function is the early marker. But if a patient has established RV dysfunction, then it indicates the poor prognostic marker. From the apical fourth chamber view by pulse wave Doppler of the tricuspid inflow, tissue Doppler of the tricuspid annulus. It is just like the LV diastolic function. Here we will take the tricuspid valve. First pulse wave Doppler, then A ratio he has measured, then TDI in the lateral tricuspid annulus, then we measure E prime and A prime. We grade E ratio less than 0.8 suggests impaired relaxation. If E ratio is 0.8 to 2.1 with E by E prime ratio more than 6, it suggests pseudo-normal feeling. If E ratio is more than 2.1 with deceleration time is less than 120 milliseconds, suggestive restrictive feeling. Now pulmonary artery pressure. Pulmonary artery pressure measurement or pulmonary hypertension is another lecture. I will describe some brief measurement regarding right heart assessment. First of all, pulmonary artery systolic pressure. The easiest method to assess the pulmonary artery systolic pressure to measure the tricuspid regurgitation jet and use the Bernoulli equation. Should be estimated and reported in all subjects with reliable tricuspid regurgitation jet. 4 into peak velocity of tricuspid regurgitation jet square plus RA pressure, 4 V square plus RA pressure. And normal pulmonary artery systolic pressure is less than 36 millimeter mercury. For the measurement of mean pulmonary artery pressure, there are lots of formula. Now I will demonstrate this easiest formula. Like we'll take the parasternal short axis view at the level of the great vessel, the PR jet velocity. If spectral Doppler, we take the spectral Doppler and early PR jet velocity. Here also you will use the Bernoulli equation. We'll take the early PR jet velocity. 4 into early PR jet velocity square plus estimated right atrial pressure. Estimated right atrial pressure. Here the PR velocity early is 3.05, which is the 4 V square is 37 plus right atrial pressure. For measurement of PADP, we use the end diastolic PR velocity. 4 end diastolic PR velocity meter per second square plus right atrial pressure. Here it is 2.29, 4 into 2.29 square plus estimated right atrial pressure. It is about 21 plus right atrial pressure. Then RA pressure. Measurement of RA pressure is very important. We should not give a single value for all patients. It should be individualized. First of all, we have to assess or appreciate some indirect evidences like enlarged right atrium, bulging of the interatrial septum towards the left side, enlarged coronary sinus, dilatation of the inferior vena cava, and absent and loss of inspiratory collapse of inferior vena cava. Measurement of inferior vena cava should be obtained at end of the expiration and just proximal to the junction of the hepatic vein that open into the inferior vena cava, which lies approximately 0.5 to 3 centimeter proximal to the junction of the right atrium with the inferior vena cava. It is the volume depleted patient. Inferior vena cava size is less than 12 millimeter. Here I'll describe something about the RA pressure determination by IVC diameter and collapsibility. Though American Society of Echocardiography give the upper normal limit of the inferior vena cava dilatation is 21 millimeter, but it is not suitable for our patient population. Then they indexed it with the body surface area. Body surface area, when the index with the body surface area, it is 17 millimeter. Upper normal limit is 17 millimeter when body surface area is up to 1.55 meters square. And our patient population is contain this group, mainly this group. At 21 millimeter, when BSA is more than 1.71 meters square, it is more for the robust patient like American people. And most of our echocardiography machine, when we input weight and height, echocardiography machine automatically calculate the BSA. So we don't have to BSA manually for every patient. Machine will do for us. Now, when IVC diameter is normal and collapsibility with sniff is done 50%, then estimated right atrial pressure is normal, which is about 0 to 5. When IVC diameter is enlarged, and collapsibility is less than 50% with sniff, then it is 15 millimeter, which reference value is 10 to 20 millimeter. Our intermediate is in between this. Now, why sniff is necessary? Sniff is preferred than the normal inspiration because normal inspiration is not sufficient for the collapsing of the IVC. Sniff is the exaggeration of the normal inspiratory process. It decreases during sniff. It decreases intrathoracic pressure as well as increase the intra-abdominal pressure. For that reason, blood flows quickly from the inferior vena cava to the right atrium. For that reason, brief and sudden emptying of the blood from the IVC into the right atrium causes IVC is briefly collapsed. But there is some exception of the RF patient. In case of ventilated patient, dilated IVC does not correlate with increased right atrial pressure. But if the IVC diameter is less than 12 millimeter, it is 100% specific for ventilated patient. The right atrial pressure is less than 10 millimeter mercury. In young patient and athletes can have dilated IVC in absence of other features of the right atrial pressure in setting of normal right atrial pressure. Now, measurement of the pulmonary vascular resistance. An elevation of pulmonary artery systolic pressure does not always imply an increased pulmonary vascular resistance. Pulmonary vascular resistance distinguish elevated pulmonary pressure whether due to a high flow from that due to pulmonary vascular disease. The estimation of PVR is not adequately established to be the recommended for the routine use. This is the formula for the measurement of the pulmonary vascular resistance. This formula also will calculate by the EPIC or advanced machine for the echocardiographer. Machine will help echocardiographer to calculate this formula. It is calculate, if you calculate this manually, we'll take the tricuspid regurgitation velocity maximum by RVOT TVI into 10 plus 0.16. Significant pulmonary hypertension exists when PVR is more than 3 Wood units. Now, how can we differentiate a patient with pressure overload from the volume overload? We'll take short axis view at the level of mitral valve or in the papillary muscle. Then we can appreciate the D-shaped left ventricle, and a D-shape is maintained both in systole and diastole in case of the pressure overload, but it also only maintained in the diastole in case of volume overload. Now 3D RV volumes. 3D echo is a promising technique. It is possibly overcomes geometric limitation of the 2D echo. It is a good correlation with MRI right ventricular ejection fraction. It has good reproducibility. RB 3D echo give reasonably accurate estimation of right ventricular end diastolic volume, end systolic volume, and right ventricular ejection fraction. In laboratories with good 3D platforms with experienced operator, 3D derived RV ejection fraction should be considered as a method of quantified RV systolic function. The lower normal limit of RV systolic function in 3D is 45%, which is higher in women and older age. Now longitudinal strain and strain rate. Strain is defined as the percentage change in the myocardial deformation, while strain rate represents the rate of deformation of myocardium over time. It overcomes most of the limitation of the conventional echo. It has one-dimensional, two-dimensional, even three-dimensional strain. 2D strain is angle and load independent and can be measured regional and a global RV function. Global longitudinal strain of RV free wall is more than minus 20%, which is likely to be abnormal. Now, this is the minimum proposed adoption to normal protocol. First of all, in the apical four-chamber view or the RV focus view, we can measure RV basal dimension, trace RA area, TAFC, TDI S prime velocity, and fractional shortening. In subcostal view, we can take the RV wall thickness and IVC studies. Some numbers to be remembered, like TAFC should be, it is a normal limit, more than 17, fractional area change more than 35, TDI SPM is more than 10 or 9.5 centimeter per second, MPI in case of in case of pulsar it is less than 0.43, in case of TDI it is less than 0.54, LV free wall strain is more than minus 20%, RV mid, there's some measure size less than 35 mid, RV area less than 18 centimeters squared, and RV OT proximal is less than 33 millimeter. So where do you stand in day-to-day clinical practice? We should take good clinical assessment of the patient, use all possible imaging windows, visual impression of the RV size, contractility, and thickness is the starting point. Use simple and reproducible method for routine studies like fractional area change, TAFC, MPI, and TDI S prime. More sophisticated methods like strain, 3D are reserved for the clinical, specific clinical and research applications. Now, I'm going to tell a story of unfortunate young man who is 32 years and came to us with the features of congestive heart failure. And he had a history of AIC implantation 6 years back. This was his ECG, epsilon was appreciated. This was his X-rays. When we do echo, we find markedly dilated right ventricle, RVOT, reduced TAFC, which is about only 8 millimeter. And S prime is 5, and E by E prime, which is diastolic function, is 7.4. When we examine the apical four-chamber view, we can see very nicely that the RV is dilated, and there is the AIC lead in the lead is seen in the RV apex, and decreased motion in the RV free wall. The most with these findings, we suspect this patient has an ARVD, and the most suggestive findings in echo for ARVD or C is the RV dilatation, enlargement of the right atrium, isolated dilatation of RVOT, increased refractability of the moderator band, and local lens aneurysm, decreased fractional area change, akinesis or dyskinesis of the inferior wall and the RV apex. In this time, we discharge the patient after improvement with anti-failure treatment and discharge with anti-failure and anti-ARB treatment. But after a few days, patient come with deteriorated states. This time, we appreciated spontaneous echo contrast in the RV, spontaneous echo contrast in the RA, and when we see and give proper attention to the RA-RV, we find multiple thrombus in the RA and RV. RA-RV and RV is minimally moving, but with all our effort and our minimal minimal resort, we failed to make this patient survive in this time. This is the history of another unlucky woman who presented in NICVD CCU with respiratory distress, chest pain, and cardiogenic shock. In parasternal long axis view, we appreciated RV is a bit dilated. In parasternal short axis view, we appreciated D-shaped RV with mild pericardial effusion. And when we moved to parasternal short axis view at the level of the great vessel, we found mass in the main pulmonary artery extending into the right pulmonary artery and also in the left pulmonary artery. And this patient also failed to survive. My take-home message: though neglected, RV function assessment is very important for diagnosis and prognosis of many cardiac and pulmonary disease. Pulmonary hypertension and RV dysfunction associated with increased mortality in heart failure, COPD, and interstitial lung disease. Proper assessment of right ventricular function is an art. We have to give proper attention in this regard. Thank you all for giving me attention.
Thank you, Dr. Shahana. It was a nice presentation. It was a brilliant presentation. Can you stop sharing your?
Yes.
Yes. So we have got some questions for you. One of the question is, sometimes we have got problem in visualization of the RV. How can we better visualize this RV? What is the way of visualization of RV? Dr. Shahana, can you hear us?
Yes. First of all, আমি একদম প্রথম থেকে বলেছি যে আরভির জন্য অনেকগুলি ভিউ আছে। আমাদের প্রত্যেকটা ভিউ মানে সিস্টেমেটিক্যালি মেটিকুলাসলি ইভালুয়েট করতে হবে। প্যারাস্টার্নাল লং অ্যাক্সিস, প্যারাস্টার্নাল শর্ট অ্যাক্সিস, at the level of great vessel, mitral valve, at the level of papillary muscle. Then we'll evaluate the apical fourth chamber. If we can visualize, then we can go for RV focus view. RV focus is a very nice view. For the proper visualization of the RV focus view, we just go one space above and anterior rotation, and we can also visualize RV in the subcostal view, subcostal long axis, subcostal short axis. When we assimilated all the view, we can assess, we can have an impression of the RV nicely.
Thank you. Another question for you. There is two ways of measuring TAPSE. One is the vertical height, another one is the slanting height. Which one do you prefer?
TAPSE আমি ভার্টিক্যাল হাইটে করি, অথবা আমি যদি হচ্ছে গিয়ে স্লপ ক্যালিপার ইউজ করি অথবা ভার্টিক্যাল ক্যালিপার ইউজ করি, মেজারমেন্ট কিন্তু একই আসবে। কিন্তু ইম্পর্টেন্ট কি, আমাদের এন ডায়াস্টোল টু এন সিস্টোল হচ্ছে কিনা, আমাদের ইসিজি গাইডেড হচ্ছে কিনা, ওই জিনিসটা মেজার করা, যে আমাদের ওই সময়টা কার্ডিয়াক সাইকেল ওই সময়টা আমরা ওই জিনিসটা মেজার করতেছি কিনা, দ্যাটস ইম্পর্টেন্ট। ভার্টিক্যাল করি, স্লপ ক্যালিপার করি, মেজারমেন্ট একই আসবে।
So this is also important. Dr. Manwar, have you got any suggestion regarding this?
Yes, if we can perform the vertical alignment, this is always better. This should be preferred over the slanting alignment, number one. Number two, whenever we are measuring ultimately the difference between the peak and trough in the M mode, in that case, we should routinely use the slope caliper option if it is available in the machine.
Thank you. In fact, there is some confusion regarding this measurement, vertical height or slope caliper. If you go through the different guidelines of RV, of American Society of Echocardiography or British Society of Echocardiography, everyone is showing the vertical height, but the 2D measurement guideline in 2019, they have shown the slope type of things. I think for the beginners, it is better to go for the vertical height.
আগে হচ্ছে যে স্লোপ ক্যালিপারটা মেশিনে ছিল না, এখন কিন্তু এখনকার মেশিনগুলি স্লোপ ক্যালিপার দিয়েছে আসলে।
কিন্তু অধিকাংশ মেশিনে নাই।
স্লোপ ক্যালিপার যখন ইউজ করা হয়, ও কিন্তু ভার্টিক্যাল হাইটটাই ক্যালকুলেট করে।
হ্যাঁ, একই হাইট, একই হাইট আসে। হ্যাঁ,
of course. We have got what is the echo finding in pulmonary embolism?
ইকো ফাইন্ডিং পালমোনারি এমবোলিজম প্রথম হচ্ছে আমাদেরকে সাসপেক্ট করতে হবে যে পেশেন্টটা, আমি যেটা বলছি প্রত্যেকটা পেশেন্টের ক্লিনিক্যাল ফিচার্স ইম্পর্টেন্ট। যেমন আমার এই পেশেন্টের ক্ষেত্রে যে একদম 42 ইয়ার্স ইয়াং লেডি আসছে, সিভিয়ার রেসপিরেটরি ডিস্ট্রেস, চেস্ট পেইন অ্যান্ড শক। এই পেশেন্টটাকে যখন আমরা দেখছি যে প্যারাস্টাল লং অ্যাক্সিস ভিউতে হচ্ছে কি আরভি এনলার্জমেন্ট, কিন্তু আরভি এনলার্জমেন্ট কিন্তু খুব প্রোনাউন্স না, ইট ইজ সাসপেক্টেড। দেন আমরা যে জিনিসটা হচ্ছে ইকো ফিচার্স এর মধ্যে, তারপর যখন আমরা প্যারাস্টাল শর্ট এক্সিসে গেলাম যে আমরা ডি শেপ আরভি পেলাম, এবং এখানে আরেকটা জিনিস খুব ইম্পর্টেন্ট জিনিস, যেখানে আমরা কিন্তু মাইল্ড পেরিকার্ডিয়াল ইফিউশন পেয়েছি। তারপরে আমরা যেটা হচ্ছে কি আমরা মুভ করবো, সুইপ করবো টুয়ার্ডস দ্য গ্রেট ভেসেল লেভেল। সেখানে আমরা মানে একদম মেটিকুলাসলি দেখবো এমপিএ, আরপিএ, এলপিএ যতটুকু আমাদের ইয়েতে দেখা যায়। কিন্তু আসলে সত্যি কথা কি, এটা তো সবকিছু সবসময় আমরা ইকোতে পাবো না। খুব যখন বড় হবে, প্রোনাউন্সড হবে, তখন উই ক্যান অ্যাপ্রিসিয়েট ইন ইকো। যখন এটা হচ্ছে পেরিফেরিতে থাকবে, আরো ইয়েতে থাকবে, যেটা হচ্ছে ইকো ভিউতে আসবে না, তখন আমরা আসলে মেজার করতে পারবো না বা ইন দ্য ইকো, তখন আমাদেরকে সিটি পালমোনারি এনজিওগ্রামের ইয়ে নিতে হবে, হেল্প নিতে হবে।
Can I supplement something?
Yeah, sure.
What Shahana has told, this is okay, but there are two famous signs.
Yes.
One is 60-60 sign, and another one is McConnell sign. If we consider two signs, the 60-60 sign is more sensitive and more specific. What the 60-60 sign tells, we have to perform two measurements. One is RVOT acceleration time, and another one is PASP by the ordinary methods. In case of classical acute pulmonary embolism, RVOT acceleration time will be less than 60 milliseconds, and the PASP will be less than 60 millimeter mercury, but more than 30 millimeter mercury. So this is the 60-60 sign. And another one is McConnell sign. Whenever there is acute pulmonary embolism, there are regional wall motion abnormality affecting the RV free wall. In classical form, the mid portion of the RV free wall will show hypokinesia or akinesia, but the apical region of the RV free wall will remain of normal contractility. This is called McConnell sign. This is of less sensitivity and specificity. Exactly. But when present, this can give a very important clue.
Exactly.
Can I add something?
McConnell.
Can I add something?
Sure.
One thing is that, as Shahana was pointing out, given the clinical scenario is very important. We should be aware of that. And second, when we have a unexplained slight RV dilatation, patient in shock, but LV function is quite good, we can have a look at the lower limb vessels. We may not have good transducer, but still we can have a look at that. That can help us.
Thank you, sir. Thank you, sir. Of course, there are different things like well score, different scoring system for pulmonary embolism. These are the two eco features. One is McConnell sign, which is present in 15 to 20% cases, but its specificity is very high. Another one is 60-60 sign. Both one. Dr. Shahana, is there any?
আমি কি একটু শেয়ার করতে পারি?
Sir.
এই পয়েন্টে।
বলেন স্যার।
In the COVID area, we are getting much more cases of pulmonary embolism. It is an important issue. We should have some discussion on this. Over years, what I have seen in the echocardiography is that there are features of echocardiographic features of pulmonary hypertension. Pulmonary echocardiographic features of pulmonary embolism. If you really look at that carefully, there are some minor signs and major signs. Some of them ought to be presented during pulmonary embolism, because subacute pulmonary subacute or acute COPD is rather common. Pulmonary hypertension is one of the important measures that we often get in patients having pulmonary embolism. Now known is happy hypertension, and many pulmonary embolism cases are actually in the community, not even in the COVID area, not even in the COVID area. During normal time, you have much more cases of pulmonary embolism, which may present as shortness of breath of unexplained origin. And if you look carefully at the echocardiogram for this, you ought to get some picture like normal RV, of the and other features like enlargement. Actually, and pulmonary embolism, both the topics are being underestimated, but it prevails in the community, and we should be careful about looking at echocardiography. Question of pulmonary embolism come, especially in this era of COVID era.
Thank you, sir. Thank you, sir. Another question for Dr. Shahana. Is there any effect of tricuspid regurgitation on evaluation of RV function?
If patient has RV dysfunction, we can get a proper tricuspid regurgitation is less, should be less if in presence of RV dysfunction.
This is one of the things, but another important thing is when there is severe tricuspid regurgitation, the volume dependent or load dependent measures like TSP or S prime or MPI, these are not perfect in case of severe tricuspid.
Yeah, these are not
totally. On that case, you should go for the fractional area change or other methods of or other methods. At the moment, we have got no further question. May I ask, Dr. Rejwana Rima, are you with us? Dr. Rejwana? Dr. Rejwana, are you with us?
Can I have a comment, please? I'm Dr. Usmani.
Just a moment. I'll give you some floor. Dr. ABM Abdul Salam, sir, are you with us? ABM Abdul Salam, sir? No. Okay, Dr. Usmani, you can go for it.
Thank you for giving me a chance to express myself. I like to congratulate my teacher, Professor Chaudhry Mishkat Ahmed, and the brilliant presentation from my colleague for the RV functions. That was very learning program, but especially for the RV with the experience of other imaging modalities, I would like to request for RV assessment and everything. If it is proper to having your decision in the echo, then even after doing that, please try to image like cardiac MRI for the RV assessment, because there are a lot of pathology in the RV that are now exploring, and I think because of this imaging, we are avoiding this diagnosis, and people are there who are going with many RV pathology diagnosis. I believe we should emphasize echo also, and with the echo on the final diagnosis of RV function and other pathologies, please go for the cardiac MRI. This is my
Thank you, Dr. Usmani. Thank you. One question for Dr. ABM Abdul Salam, sir. Professor ABM Abdul Salam, sir. Sir, a very specific question. That is, how can you evaluate RV function in Ebstein anomaly? Only this question, please. Professor Abdul Salam, sir, you wanted to make a comment? Okay. Now we move to Dr. Kobirujaman, sir. Dr. Kobirujaman, sir, can you answer this question? Dr. Kobirujaman, sir. Okay. May I request Professor Shahabuddin, sir, to make any comment regarding this presentation, LV function, RV function, all these things?
I want to say, like Professor Abdullah Shafi Mazumdar, the top thing has been presented very simply and very understandable way. It's very much helpful not only for the students but also for the fellows. Thanks, Professor Mishkat Ahmed sir, for his nice presentation, and also Dr. Shahana Zaman for his presentation. That was brilliant as usual. I have seen some of his presentation. It was really excellent. Thanks for both the presenter and thanks to the authority they have arranged this webinar session. Thank you very much.
Dr. Manwar, can you tell us two important things regarding LV systolic function? One is, how can we judge that we are focusing at the true apex, true LV apex? What are the parameters? How can we understand that we are getting the true apex of LV? Number one. Number two, regarding the lining, delineation of the endocardial border. What is the parameters? How can we get this endocardial data?
Thank you, Firoz bhai. The common practice is that in case of echo interrogation, the left ventricle is usually foreshortened. The problem is that foreshortening of the left ventricle is the usual trouble. To avoid this trouble, we have to go to the apical 4-chamber view or 5-chamber view or 2-chamber view and look for the apex. If the LV is not foreshortened, then we will get the apex truly, and the apex will move and contract in its usual manner. In the long axis, apex move less, but we can beautifully see the movement from side to side. So this should be visible. And for the delineation of endocardial border, the good quality image as well as the optimum settings are must. If still we cannot have a good quality endocardial delineation, in that case, even after applying the harmonic imaging and other things, we have some options like LV contrast echo. Though LV contrast echo is not available in Bangladesh, but we can certainly try to have the contrast agents like Definity and Sonoview, which are available in India, and we can try to utilize this phenomenon.
Thank you, Dr. Manwar. One important regarding the LV apex for these students, it is important to memorize or think, keep in mind that the LV apex has got no longitudinal motion because the whole heart moves towards the apex longitudinally. When you will get the true apex, it will not move longitudinally. There may be some twisting or side-to-side movement, but there will be no longitudinal movement of the LV apex. This is one important thing. And when you cut the LV, it is the longest vertical diameter which will pass through the apex almost always. These are the two important things you can keep in mind. Another thing is regarding the trabeculae of LV.
Can I add something? Longitudinal movement. But in case of aneurysm, in case of aneurysm, there will be outwards movement, bulging.
Yes. Bulging,
but not inward.
Another important thing is the trabeculae of LV, which is a normal part of LV, normal anatomy. Sometimes there may be trabeculation, increased trabeculation in case of other diseases. The trabeculae is part of LV cavity. So you have to delineate the compacted portion of the LV wall, LV myocardium. Inner border of the compacted portion of the LV myocardium, that is the inner lining of the outer lining of the LV cavity. These are the two simple things you can keep in mind regarding the Simpson method. Most of the machines measured it by two planes, that is the longitudinal 4-chamber and 2-chamber. In 3D echocardiography, it measures in 3-chamber, three planes, in fact.
I'd like to give another message. That is, in the modern machines, there are some sort of artificial intelligence. Like in Vivid, you can press the button auto, and whenever you are just pressing the button auto, there will be better delineation of the endocardium. In case of Philips machine, another button like eye scan. Whenever you are pressing the eye scan button, there will be better delineation of the endocardium often. But despite all the rules and provisions to date, you may not be able to find out the endocardium. In that case, you have to take the help of
Dr. Kobir Jaman sir. Sir, are you with us? Dr. Kobir Jaman sir? No. Dr. Professor Tawfiq?
Firoz, can I add something else?
Sir.
Also, most of the echocardiographers are doing, they're finding M mode. And they often take the shadow created by the trabeculae or the peptide muscle, not actually the endocardial surface as the endpoints of determining the systolic diameter and diastolic diameter. That's the problem.
Okay. We have got Dr. Govindo Pal.
Dr. Firoz, I have a question to Dr. Shahana regarding TAPC. For screening purpose, we used to do in the Echo Lab, the TAPC is a screening method to assess the right ventricular function. And what are the limitation of the TAPC? In which condition it may give false impression for measurement of the TAPC for RV systolic assessment?
TAPC is gives longitudinal function of the right ventricle. longitudinal function in a single point estimation of the RV function, and it is load dependent and angle dependent. This is the limitation of the testing. In case of regional RV systolic dysfunction like RV infarction, we can't, TAFSI is not a good predictor. Then we have to take other measures for the proper assessment of the RV.
Exactly. It is a angle independent, so the movement of the annulus should be parallel to the cursor of the M mode. Number one. Number two, it is a load dependent one that should be measured. That's why it is not appropriate for tricuspid regurgitation. Another important thing is in post-operative patient. In post-operative patient, longitudinal function measurement is not an exact evaluation of the RV function.
Because
Dr.
pericardium
Govind
is separated then.
Yes, Dr. Govindopal, do you have got any comment?
Yes.
Sure.
Thank you, Mohammedullah Firuz Bhai, for your brilliant moderation. I'd like to comment regarding the second talk, Dr. Shahana Jaman, outstanding, no doubt. And I have something about the McConnell sign regarding pulmonary embolism. Usually it is used in acute massive pulmonary embolism, and in that case, mid portion of the lateral of the RV is hypokinetic and sparing the RV apex usually. And I'd like to ask about the, in case of RV infection, in case of inferior MI, how can you evaluate RV function? Is it FC or TDI?
In the RV infarction, then a fractional area change give a good estimation of the RV function. Fractional area change, which is not load, and then RV strain is another thing. But TDI, SOF or SOF or TAFSI is not the good predictor. And we can also use the RV diastolic function, E by E prime. It is also a good predictor for the RV infarction, in case of RV infarction.
Thank you. Another question from my teacher, Professor Chaudhary Mashkat sir. Excellent presentation, no doubt. Very simple way. I've asked one question: when the left ventricular hypertrophy severely thickened interventricular septum and sometimes ASOCM or ACM when merges with the lateral wall of the right ventricle, how can you differentiate between the interventricular septum and lateral wall? If any tips and tricks or any comments. Thank you, sir.
Possibly I could not get your question, but if the interventricular septum is intermingled with the right ventricular free wall, how to differentiate this right ventricular free wall from the interventricular septum?
During measurement of Tycho's method, of the LV.
To be honest, এটা আমার কখনো চোখেও পড়ে নাই, মনেও হয় নাই কখনো যে আরভি এর ওয়ালটা আসলে সাথে হয়তো it is there, but I have really missed it. কিন্তু সবসময় কালার মোডটা ইউজ করতে হয় আর কি হাইপারট্রফিক কার্ডিওমায়োপ্যাথিতে, আদার কালার যে কালারটাতে খুব ভালো ডেলিনিয়েট করা যায় ইন্টারভেন্ট্রিকুলার সেপ্টাম,
ডিফারেন্ট সর্ট অফ বি মোড ইমেজ,
রেজুলেশন কমানো বাড়ানো বা এটাকে গেইন কমানো বাড়ানোর ব্যাপার আছে না, গেইন বাড়ানো কমানো বা
এফসিন অ্যানোমালি সম্বন্ধে নাহরুমা
মেশিন আমি শেষ করে নিই। মেশিনটা অ্যাডজাস্ট করতে হয়। আরবি ফাংশন সম্পর্কে আমার মনে হয় একটু আমি বলতে চাই, যদি আমাকে একটু সময় দেন। পর
অবশ্যই
বলবো না, পরে নেহরুমা বলার পরে।
না স্যার আপনি বলেন স্যার।
আচ্ছা, আরবি ফাংশনের ব্যাপারে সেমি কোয়ান্টিটিভ মেজার হিসেবে ধরা হয় এফএসি, ফ্র্যাকশনাল এরিয়া চেঞ্জ। সেটা হলো সবচেয়ে স্ট্যান্ডার্ড, সেটাকে বলাই হয় যে সেমি কোয়ান্টিটিভ। নো আরবি ফাংশন ইজ কোয়ান্টিটিভ বিকজ অফ দি মরফোলজি অফ আরবি এক্সেপ্টিং দি থ্রি ডাইমেনশনাল ইকোকার্ডিওগ্রাফি। এটা খুব ক্লিয়ার হওয়া উচিত আমাদের যে আরবি ফাংশন যদি বুঝতে হয়, আমরা আরবি ফাংশন বলতে যা বোঝাই সেটা কিন্তু 3D ছাড়া সম্ভব না। অফকোর্স এমআরআই ইজ দ্য গোল্ড স্ট্যান্ডার্ড। আর বাকি আমরা যাই দেখি সব কিন্তু সারোগেট মার্কার, কিন্তু এই সারোগেট মার্কারদের মধ্যেও সেমি কোয়ান্টিটেটিভ হিসেবে ধরা হয় হলো ফ্র্যাকশনাল এরিয়া চেঞ্জেস। দেয়ার আর স্টাডিজ হুইচ হ্যাভ শোন ডিফারেন্ট মেথড অফ আরবি এস্টিমেশন। একটা হলো নর্মাল আরবি থাকলে কোন প্যারামিটারটা ভালো, আর কোনটা আরবি যদি ফাংশন ডিপ্রেস থাকে তাহলে কোন ফাংশনটা ভালো। বলা হয় যে ফ্র্যাকশনাল এরিয়া চেঞ্জ দুইটা ক্ষেত্রেই ভালো, কিন্তু এমপিআই যখন আরবি ফাংশন ডিপ্রেস থাকে তখন এমপিআই হয়তো ভালো। একটা জিনিস বলতে চাই, সেটা হলো যে স্ট্রেইন সম্পর্কে, আরবি স্ট্রেইন সম্পর্কে মনে হয় যে নতুন জিনিস 2D স্ট্রেইন অফ দ্য আরবি। আরভি ফাংশন সম্পর্কে একটা ভালো, কিন্তু এটা কোনোটা মানে কোনো মেজারই মানে অ্যাকিউট কিংবা যদি ডিপ্রেস থাকে আরভি ফাংশন কোথাও এটা সুপেরিয়রিটি আমাদের কনভেনশনাল মেথডের চেয়ে ভালো না। কিন্তু 3 ডাইমেনশনাল ইকোকার্ডিওগ্রাফিটা খুব ইম্পর্টেন্ট। আরভি ফাংশন সম্পর্কে একটা কথা না বললেই না, সেটা হলো যে ইন অ্যাডাল্ট কার্ডিওলজি প্র্যাকটিস হেপপেফ কিন্তু ইজ আ রিয়েলিটি। আমরা কিন্তু প্রচুর হেপপেফ এনকাউন্টার করি। হেপপেফ পেশেন্টদের কিন্তু ইনডিপেন্ডেন্ট অফ দি ডাউনগ্রেড ইফেক্ট অফ দ্য লেফট ভেন্ট্রিকল আরভি ইনভলভ হতে পারে ইন্ডিপেন্ডেন্টলি অফ এলভি। তো এই অ্যাডাল্ট প্র্যাকটিস এই জিনিসগুলো যদি মিস করে যাই আমরা কিন্তু ইকোর একটা বড় ফাংশন হলো টু অ্যাসেস দ্য প্রগনোসিস অফ আ পার্টিকুলার পেশেন্ট। তো অ্যাডাল্ট প্র্যাকটিসে আমাদের জন্য একটা পেশেন্টের প্রগনোসিসের জন্য আরভি ফাংশনের যে ইম্পর্টেন্স সেটা কিন্তু মিস হয়ে যাবে ইফ ইউ ডু নট রিয়েলি লুক অ্যাট দ্য আরভি ফাংশন। এটা খুব মনে রাখা জরুরি, আমি মনে করছি রিয়েল লাইফের জন্য জরুরি। থ্যাংক ইউ।
Thank you, sir. May I request Dr. Naruma to say in brief about the assessment of RV function in, not anatomy, only RV function in Epstein anomaly.
Thank you, sir. RV function of Epstein is very tough because it depends, the functional RV is depending upon the severity of Carpentier type 1, type 2, type 3. And the RV cavity is divided into atrialized and functional RV. So the RV is rudimentary. So best option is eyeball estimation, because here the TAPSE is not possible because the septal leaflet is tethered with interventricular septum. So excursion is not possible. So TDI and all that fractional area shortening, this is not possible for Epstein anomalies. So indirect evidence and RA dilatation, RA volume, intraarterial septum directed to LA, and the atrialized portion of RV. In that portion, we will find that the IBS is directed towards LV. So there is annular dilatation also, and RV base diameter is also increased. And we can see also the RVOT proximal or RVOT diameter in subcostal sagittal plane. That also give the clue of the RVOT diameter and the PA anatomy. And also the TR gradient also give the TR gradient, the PSP. In that, all evidence, supportive evidence, give the evidence of RV function. Most important is RV function, eyeball estimation of RV contraction of functional RV, and indirect evidence by the RA, intraarterial septum, annular dilatation in that things. But typical, all that criteria, that S-wave, TDI, EF, that will not, we can give from the RV function traditionally, not will give from in Epstein anomaly.
Thank you. Thank you, Dr. Naruma. Probably, sir.
Dr. Firoz,
sir.
আমার মনে হয় প্যানেলিস্টদের বলতে দাও এখন।
স্যার বলতেছি স্যার। জি স্যার প্যানেলিস্টদের বলতে দিচ্ছি। Now may I request Professor Taufikur Rahman. Professor Taufikur Rahman, your comment regarding today's presentation.
Assalamu alaikum. Thanks to Professor Abdullah Shafi Mujumdar sir, director, course director, and Dr. Firoz Bhai and Dr. Monwar, course co-director, for arranging such a good webinar and learning platform. যদি ইয়ার প্রেজেন্টেশন সম্বন্ধে বলি, আসলে খুবই প্রেজেন্টেশন দুইটা খুবই সুন্দর হয়েছে এবং খুবই আন্ডারস্ট্যান্ডেবল হয়েছে, খুবই কম্প্রিহেন্সিভ প্রেজেন্টেশন এবং খুবই বেসিক জিনিস নিয়ে আলোচনা করছে। এজন্য থ্যাঙ্কস মেশকাত স্যার এন্ড থ্যাঙ্কস টু শাহানা জামান। এবং শাহানা পুরো স্টেপ বাই স্টেপ টোটালি সুন্দর করে আরবি সম্পর্কে আমার মনে হয় যারা আন্ডার গ্রাজুয়েট স্টুডেন্ট, এখানে পোস্ট গ্রাজুয়েট স্টুডেন্ট আছে, ফেলোজ আছে, তাদের জন্য খুবই সহজে এটা বোঝার মতো হয়েছে। আর দুইটা কেস প্রেজেন্টেশন করছে। আমি আসলে একটু অন্যভাবে একটু জাস্ট আরভি সম্পর্কে এবং লেফট ভেন্ট্রিকুলার সিস্টোলিক ফাংশন সম্বন্ধে একটু একটা করে একটু কথা বলি আর কি। জাস্ট একটা কেস প্রেজেন্টেশন। আমার এক পেশেন্ট ঢাকা কলেজের আর কি, ও ইয়ং ছেলে, 20 বছরের এরকম, 20-22 বছর বয়স হবে, অনার্স পড়তেছিল। তো ওর হলো যেটা হিস্ট্রি বলার উদ্দেশ্য হলো যে ও শ্বাসকষ্ট নিয়ে যখন আমাদের কাছে আসছে তখন অলরেডি আসলে এই গত 5-6 বছর ধরে তাকে আসলে ট্রিটমেন্ট করতেছিল, ব্রঙ্কিয়াল অ্যাজমা করে চেস্ট স্পেশালিস্ট এন্ড আদার্স তাকে ট্রিটমেন্ট দিচ্ছিল। তারপরে যখন আসে তার যখন করা হয় তখন আরভি অ্যাসেসমেন্ট এবং আরভি ফাংশন খুব খারাপ অবস্থা। আলটিমেটলি আসলে কিছুদিন ওকে রেফার যখন এনআইসিবিডি এবং বিভিন্ন হাসপাতালে, হার্ট ফাউন্ডেশন, এনআইসিবিডি, ঢাকা মেডিকেল কলেজে ঘুরে আলটিমেটলি হি ডাইড। বলার উদ্দেশ্য হলো যেটা আসলে সেটা হলো যে কোনো শর্টনেস অফ ব্রেথ নিয়ে যদি কোনো পেশেন্ট আসে আসলে যে কোনো পেশেন্ট আমরা অনেক সময় ইয়ং মহিলা বা ইয়ং ছেলে আমরা একটু উড়াই দেওয়ার এনার সাইকোজেনিক বা এরকম অন্য সমস্যা হতে পারে, আমরা কিন্তু এটাকে অনেক সময় ওভারলোক করার চেষ্টা করি। এবং সেক্ষেত্রে যারা অনেক সময় শ্বাসকষ্ট নিয়ে চেস্ট স্পেশালিস্ট বা মেডিসিন স্পেশালিস্টের কাছে যায়, হয়তো অনেক সময় তারা ইকো পাঠায় বা ইকো পাঠায় না। আর যারা বিজি প্র্যাকটিশনার আছেন, স্পেশালি চেস্ট স্পেশালিস্ট বা মেডিসিন স্পেশালিস্ট, তারা অনেক সময় কোনো ইনভেস্টিগেশন দিতে চান না, তারা ওই একটা ওষুধপত্র দিয়ে যান। এই ক্ষেত্রে হলো যে সমস্যা যেটা, ওই রোগীগুলা আসলে পরবর্তীতে সাফার করে যখন আরবি ডিসফাংশন হয়ে যায়, তখন আসলে প্রাইমারি পালমোনারি হাইপারটেনশন আছে ডায়াগনোসিস হয়, আলটিমেটলি তখন কিছু করার থাকে না। এই ক্ষেত্রে যারা অ্যাটলিস্ট এটা মেসেজ হলো যে যারা শ্বাসকষ্ট নিয়ে যায় এইসব রোগীর ক্ষেত্রে পালমোনারি হাইপারটেনশন আছে কিনা, আসলে প্রাইমারি পালমোনারি হাইপারটেনশন এবং আর্লি স্টেজে এটা ডায়াগনোসিস করার জন্য যায় কিনা, এটা আসলে দেখা উচিত এবং সেভাবে আসলে ট্রিটমেন্ট করা উচিত। এটা হলো আমার একটা গেল। আর একটা যেটা আমিও দেখি খুব কমনলি, সেটা হলো যে মাইটাল স্টেনোসিসের রোগী অথবা কার্ডিওমায়োপ্যাথি রোগী, এগুলো আসলে খুব নেগলেক্টেড হয়। এরাও শ্বাসকষ্ট নিয়ে যায় বিভিন্ন জনের কাছে এবং তাদেরকেও আলটিমেটলি যখন ইকো করা হয় বা যখন এক্সরে করা হয়, যখন কার্ডিওমেগালি দেখে, আসলে তখন আমাদের কাছে রেফার করে, তখন আসলে মানে লেট স্টেজে চলে যায়। এটার ক্ষেত্রে হলো একটা। আর একটা যেটা বলতে চাই সেটা হলো যে আফজাল স্যার ওই দিন বলতেছিল, এটা একটু ভালো লাগছে, যে আমাদের পিটিএমসি করার ক্ষেত্রে আমরা যেমন বলছি যে এটা কি মাইটোলোসিস সিভিয়ার বা মাইটোলোসিস মডারেট, কোন ক্ষেত্রে আমরা পিটিএমসি করব। বলছে মাইটোলোসিস মডারেট যদি থাকে কিন্তু রোগীর যদি সিমটম থাকে, আসলে এই স্টেজে আমাদের পিটিএমসি করে দেওয়াটা উত্তম। সেক্ষেত্রে হলো যে যেহেতু তাদের আরভি ডিসফাংশন হওয়ার আগে করে দিলে পরবর্তীতে আরভি ডিসফাংশন যখন সিভিয়ার কন্ডিশনে হয়, আরভি ডিসফাংশন হয়ে যায়, তখন আসলে আউটকামটা ভালো হয় না। উল্টা দেখা যায় মাইটাল লিগাজিটেশন বা ডেভেলপ করে অ্যাকুট এমআর বা রোগী আসলে খারাপ অবস্থা চলে যায়, তখন ভালভুলার চেঞ্জও আসলে খুব ক্যালসিফিকেশন আর আদার্স চেঞ্জেস ডেভেলপ করে, সাবভালভুলার চেঞ্জেস অনেক হয়ে যায়। এক্ষেত্রে মেসেজটা হলো যে যদিও তারা এমএস মডারেট আছে বা এমএস যদি মাইল্ড টু মডারেট হয় এবং সাথে যদি দেখা যায় যে তাদের রোগী সিমটোমেটিক হয় এবং যদি সিমটোমেটিক দেখা যাচ্ছে ডায়াবেটিস দেওয়ার পর ইমপ্রুভও করে গেল, আসলে সেসব ক্ষেত্রে আমার মনে হয় বেটার তাদের হলো পিটিএমসি করে দেওয়া। এটা গেল ইয়ের ক্ষেত্রে, রাইট ভেন্ট্রিকুলার ফাংশনের ক্ষেত্রে। আর লেফট ভেন্ট্রিকুলার সিস্টল ফাংশনের ক্ষেত্রে আসলে আমি একটু একটা জিনিস অ্যারেস্ট করতে চাচ্ছি, যেটা মজুমদার স্যারও আছেন এখানে বা সিনিয়র কার্ডিওলজিস্ট আছে, সেটা হলো যে আমরা রুগী যখন আসে, অনেক সময় রুগী সেলফে আসে বা রুগীর কোনো ডাক্তার রেফার করলো, আমরা ইকো করার সময় ইকো করা মাঝখানে হয়তো রুগীরা জিজ্ঞেস করে, স্যার আমার রিজার্ভ ফ্র্যাকশন কত। যখন এরকম কথা জিজ্ঞেস করে তখন স্বাভাবিকভাবে আমরা একটু হয়ে যায়। তা বলে আমি জিজ্ঞেস করে, আচ্ছা কেন, কি ব্যাপার, আপনার আসলে এটা জানতে চাচ্ছেন কেন? বলে না স্যার, এর আগে ইনজেকশন ফ্র্যাকশন করছিলাম, তো আমি হয়তো বাইপাস করছি অথবা আমি স্ট্যান্ডিং করছি বা এর আগে আমার এমআই হয়েছিল, সে ফলো আপ করতেছে, সে হয়তো জানতে চাচ্ছে যে এর আগে যে ইকো করছে তার হয়তো আছে 45%, এখন সে ইকো করতে আসছে তার উন্নতি হলো কিনা এটা জানার জন্য। তখন হয়তো তাকে বুঝাই দিতে হয়। এখন আপনি যদি বলেন 45 হয়েছে, এখন আপনি যদি দেন 44 বা 42 43 অথবা আপনি যদি 46 যেটাই দেন না কেন, রুগী আসলে কনফিউজ, আমার কি তাহলে ভালো হইলো না খারাপ হইলো, কারণ রুগী আসছে কিন্তু এই নাম্বারটা জানার জন্য। এখন সেক্ষেত্রে আমার সাজেশন, মানে আমার ইয়েটা হলো যে স্যার এরকম আসলে কি আমাদের রিপোর্টের মধ্যে এই যে আমাদের যে প্যারামিটার উল্লেখ করি আমরা, এই প্যারামিটারটা আসলে জরুরি কিনা সবার ক্ষেত্রে, এটা আসলে যারা বিজ্ঞ আছে তারা বলবেন। আর একটা হলো যে যদি জরুরি হয় তাহলে সেক্ষেত্রে স্যার আমরা প্যারামিটার যেটা আছে, যেমন আমরা সিস্টোলিক ফাংশন নির্ণয় করার জন্য দেখি যে আমাদের অনেক সময় 3 বার করলে দেখা যায়, যদি সিমসন মেথডে করি 3 বার বা 4 বার করলে 4 ধরনের আমার রিডিং আসে। তাহলে কি আমরা কোনো রেঞ্জ দিব কিনা, যে হলো যে ঠিক আছে এলভি আইডিডি এলভি আইডিএস এত থেকে এত, ইজেকশন ফ্র্যাকশন এত থেকে আছে, এফএস এত থেকে এত, সেটা আমরা কি দিতে পারি কিনা, নাকি আসলে আমাদের একটা মেজারমেন্টে আসলে ফিক্স থাকা উচিত যে একটাই দেওয়া উচিত? এটার ব্যাপারে আসলে সবার দৃষ্টি আকর্ষণ করতেছি। সবাইকে অসংখ্য ধন্যবাদ। থ্যাংক ইউ এগেইন। সালাম স্যার।
Thank you, Professor Tawfiq. Now I would request Professor Tuhin Haq, Madam, to give some comments regarding the 2 lectures, regarding the question of Professor Tawfiqur Rahman, and also to talk a brief 1 or 2 minutes regarding the role of strain in assessment of the LV systolic function, because you are doing so much strain in your setup. Professor Tuhin Haq, Madam.
Thank you, Firoz. Assalamu alaikum, and it's already afternoon, so very good afternoon. I'd like to thank the organizing committee to give me this opportunity and invite me as a panelist. my heartfelt thanks to Professor Shafi Majumdar sir because it is his initiative to organize this platform to learn ECHO, not for the fellows only. It is also helpful for the cardiologists who want to update their knowledge on ECHO. Regarding today's lecture, Dr. Joseph about many aspects of LV ejection, LV systolic function evaluation, just to make it easy that. So just to make it easy, that how to start with evaluation of the LV shape and size. Then you evaluate the LV regional no regional motion abnormality, then your global eyeball estimation, or as Dr. Mishkan had recommended, method. Though Tekus method is already obsolete by world field of echocardiography, but in absence of regional wall motion abnormality, when the global LV systolic function is normal, biplane Simpson's method is the recommended one. And your global eyeball estimation is the reliable, your number of echo first under supervision, and then you have to do independently. For biplane method, Dr. Mishra gave the accurate result. So endocardial very clearly. My eyeball estimation of LVEF. Can you hear? Can you hear?
Mobile hotspot দিয়ে যাবেন নাকি তাহলে বোধহয় ভালো হতো
disturbing.
মোবাইল হটস্পট দিয়ে যান আপা মোবাইল হটস্পট দিয়ে যাওয়া যায় কিনা দেখেন
হটস্পট দিয়ে রেখেছি
ঠিক আছে ম্যাডাম বলেন
শোনা যাচ্ছে
এখন শোনা যাচ্ছে ভালো বলেন
আচ্ছা ঠিক আছে আমার হটস্পটে দেওয়া আছে আমি যেটা বলছিলাম যে for quantitative estimation of LV ejection fraction. Now, am I audible now?
Yes, madam. Yes.
Okay. So for quantitative estimation of LV ejection fraction, that modified biplane Simpson's method is the recommended one. So Professor Chaudhary mentioned my name, but I should say that in that conference, I was lucky to get a good patient, to get a good echo window, because clear visualization of the endocardium is the must for measuring LVF by biplane Simpson's method, and it also depends on the number of echo you do. I do many echo a day, and I have to measure LVF by modified Simpson's method in many purposes, because I have to give the quantitative estimation LVF for many study and for the surgeons. So I am practiced with biplane method. And whenever 3D echo is available, 3D echo is the best for LVEF and as well as RVF measurement. And when you want to do the evaluate LV systolic function early, that is subclinical LV systolic dysfunction, before the appearance of any regional wall motion abnormality, when the EF is still normal, then strain will give you the more reliable result. So strain before the appearance of regional wall motion abnormality, when EF is still normal, if you get the global longitudinal strain less than 20%, that is below the normal range, it will indicate the subclinical systolic dysfunction. And its main role is in the field of cardio-oncology. It is before you start chemotherapy, when a patient with cancer come to you, you assess the global longitudinal strain, you keep the baseline parameter, and then after chemotherapy, you evaluate again, and you will get that whether there is any toxic effect which causes the cardiotoxicity. So a strain will give you the real assessment of the subclinical systolic dysfunction. And in case of already the ischemic heart disease and other disease, it evaluates it indicates the prognosis. So in case of OMI, it has a prognostic value. Even in case of the RV function strain, it will indicate it is a prognostic marker. So in addition to the subclinical systolic dysfunction, in case of established disease, it will help for the prognosis of the disease. And for many disease pathology like hypertrophic cardiomyopathy and many cardiomyopathies, strain has the disease specificity. By understanding the strain, you can understand the disease pathology. So if I want to say more about strain, then it will take time. So I should switch from here. So for the fellows, I want to emphasize again that LV evaluation should start from the LV shape and size, followed by regional wall motion abnormality. Then for daily practice, global eyeball estimation of LV ejection fraction. For quantitative estimation, LVEF by biplane method. And if you have 3D, 3D is the best. And the strain for advanced evaluation and most important for subclinical evaluation of LV systolic dysfunction. Okay, and then I go for RV. I should congratulate Professor Meshkat for his nice presentation and to mention the limitation of how to avoid the limitation, that is translation motion, and to avoid the foreshortening. One point I forgot to mention that while doing biplane method, biplane Simpson's method, two long axis diameter, that is long axis diameter in the apical 4-chamber and the apical 2-chamber view should nearly equal. If it differs by 20%, exactly, the column method should be disregarded. This is very important for the fellows. So I give emphasis to it. Okay, now I come to RV systolic function. Dr. Shahana very nicely presented every step for evaluation of RV systolic function. I must congratulate her. She is a brilliant presenter and mentioned, and even in her take-home message, she pointed out that the RV evaluation by all the views, from all the views are very important. RV anatomy is very complex. So you search for all the views to get the clear visualization of the RV. Then you start looking at the RV shape and RV volume. So whenever there is RV dilatation, it indicates that there is RV dysfunction. You look for the RV free wall for longitudinal contraction. As well, you look for the RV inward systolic thickening. So both the longitudinal contraction and the radial function, it will help you to assess the global RV function. And global RV systolic function is always qualitative unless you have the 3D echo that Dr. Fishana emphasized and also Dr. Meshkat emphasized. For quantitative measurement of RV systolic function, there is no alternate of 3D echo. So for quantitative measurement, 3D echo is the best, but the other day-to-day practice that as our surgeons are keen to know about RV function, TAPSE, fractional area changes, and by global eyeball station, we will measure that whether the RV function is normal or it is reduced. Reduced, what is it? Mildly reduced, moderately reduced, or severely reduced. And as the Dr. Taufik mentioned, that what should we do about EF for the patient's purpose? My suggestion that we should give the range so the patient will not be concerned that his ejection fraction is decreasing. So with that, I like to thank everybody. And my special thanks to Mahmoudullah, Firoz, and Manwar, because it is their great effort to make this program a success one. Thank you, everyone.
Thank you, Professor Tuhinat, madam. Dr. Manwar, have you got anything to add?
I like to add one thing, that regarding the mentioning the values in our final report regarding the RV systolic function, LV systolic function, the exact number, as madam has also agreed, should not be mentioned. There should be a range, maybe from 40 to 45. Another state-of-the-art technique or practice is to determine the exact Simpson biplane ejection fraction, say 34%, and then we can write down 34% plus minus 3%. This also is a good practice by some experts in echocardiography. Thank you.
Thank you, Dr. Manwar. We are already late. May I request Professor Abdullah Shafi Mujumdar sir to conclude the session?
Concluding remarks এর আগে প্রফেসর তুহিন এবং ডক্টর মনোয়ারের কাছে আমার একটা কোশ্চেন বলি যে আমাদের বিভিন্ন স্টাডি এবং বিভিন্ন গাইডলাইনে আমরা কিন্তু একটা কাট পয়েন্ট ধরি যে এই 35% এর নিচে হলে এটা করতে হবে ইজেকশন ফ্র্যাকশন, আমার 55 এর উপরে হলে এটা প্রিজার্ভ ইজেকশন ফ্র্যাকশন। এইটা কিন্তু আমাদের গাইডলাইনে যে কারেন্ট গাইডলাইন গুলিতে আছে। কাজে এই যে রেঞ্জ যে দিব এটা আমরা বললাম, কিন্তু উইল ইট বি ভেরি ভ্যালিড থিং যে আমরা একটা রেঞ্জ দিয়ে দিচ্ছি? তাইলে তো বলবে যে আমি ধরো আমি দিলাম 45 to 50, তাহলে এই পেশেন্টটা কিসের? এটা কি নর্মাল ইজেকশন ফ্র্যাকশনের পেশেন্ট নাকি মাইল্ডলি রিডিউস? এটা একটা, যাই হোক, এটা কোনো উত্তর নাই আমি জানি। দ্যাট ইজ দ্য ডাইলেমা, যে আমরা একবার বলতেছি যে আসলে ইজেকশন ফ্র্যাকশন তো ওইভাবে মেজার করা আসলে যায় না, একদম কাট পয়েন্ট, কিন্তু আমরা সমস্ত হার্ট ফেলিয়ারের ম্যানেজমেন্ট করতে আইসিডি লাগানোর বেলায়, সিআরটি লাগানোর বেলায় আমরা কিন্তু বলছি যে এইরকম একটা ইজেকশন ফ্র্যাকশন থাকতে হবে। কাজে এটা একটা ব্যাপার। আচ্ছা, আমি কনক্লুডিং রিমার্কসে আমি সবাইকে ধন্যবাদ জানাচ্ছি। প্রফেসর চৌধুরী মেশকাতকে ধন্যবাদ জানাচ্ছি যে হি এগ্রিড টু গিভ দি প্রেজেন্টেশন and he made the presentation in a simplified way, এই জন্য আমি ধন্যবাদ জানাই। ডাক্তার শাহানা জামানকে ধন্যবাদ জানাই যে সে খুব একটা এলাবোরেট প্রেজেন্টেশন দেওয়ার জন্য, এবং এটা খুব একটা ডিফিকাল্ট টপিককে তাকে দেওয়া হয়েছে, কিন্তু she took the challenge very nicely। এটার জন্য আমি তাকে ধন্যবাদ জানাই। যদিও আই উড বি হ্যাপিয়ার যদি তুমি একটা শেষে আমাদের নোভিস ইকোকার্ডিওগ্রাফারদের জন্য মাস্ট টু ডু ফর দি অ্যাসেসমেন্ট অফ দি আরবি ফাংশন, এই কয়েকটা পয়েন্ট, কারণ আমাদের এই প্রোগ্রামটা কিন্তু ফর দি নোভিস ইকোকার্ডিওগ্রাফার, নট ফর দি সিনিয়র পার্সন। আমরা যারা আছি আমরা খুব অনেক কিছু শিখছি, কিন্তু আমাদের টার্গেট অডিয়েন্স হইলো আমাদের নোভিস। কাজে নোভিসের জন্য আমাদের সব লেকচারের শেষে বোধহয় আমাদের যদি একটা থাকে যে হোয়াট মাস্ট ডু ফর দি ডে টু ডু প্র্যাকটিস ইন দি ইকোকার্ডিওগ্রাফি, এই একটা থাকলে তারা উপকৃত হবে। তো শাহানা, এটা একটা কোনো এক সময় তুমি একটা বলো যে, কারণ বেশি কঠিন করলে ওই নোভিসটা কিন্তু আর ইকো করতেই চাবে না, ইকো থেকে সরে যাবে, মনে করবে যে এটা খুব কঠিন জিনিস। ডোন্ট মেক দেম go away from the echocardiography. Echocardiography is a very simple and artistic thing. আর প্রফেসর তৌফিকের যা কমেন্ট করছে, একটা কথা আমি বলি যে আমরা কিন্তু সেট গাইডলাইনের বাইরে যে করাটা ঠিক হবে না। যেটা ও বলছে যে মাইল্ড টু মডারেট এমএসএ করব, যে আমরা কি করি, আমরা ওই সেফটি অফ দি প্রসিডিউরের সাথে বেনিফিট অফ দি প্রসিডিউরকে করি, কি বলে, ব্যালেন্স করি। কাজে any PTMC, any invasive procedure is associated with any minor degree হইলো তার একটা ফ্যাটালিটি রেট আছে। কাজে আমাদেরকে গাইডলাইনের সাথে স্টিক থাকা উচিত। এটা নট অনলি ফর দি বেনিফিট অফ দি পেশেন্ট, অলসো ফর দি মেডিকো লিগ্যাল পারপাস, যে আমি একটা ভালো পারপাসে, ইন্ডিকেটেড পারপাসে করতে গিয়ে পেশেন্টের কোনো অসুবিধা হলে, মরবিডিটি মর্টালিটি হলে উই ক্যান স্ট্যান্ড। না হলে কিন্তু আমরা পেশেন্টের ভালো করতে গিয়ে খারাপ করতে গেলে কিন্তু উই ক্যানট স্ট্যান্ড ইফ উই গো বিয়ন্ড দি গাইডলাইন। তো সবাইকে ধন্যবাদ দেই। আমাদের যারা সিনিয়র কার্ডিওলজিস্ট যারা স্পন্টেনিয়াসলি জয়েন করে, প্রফেসর আব্দুল ওদুদ চৌধুরী রেগুলারলি, প্রফেসর শাহাবুদ্দিন রেগুলারলি, এবং সবাই আমাদের প্যানেলিস্ট দে এগ্রিড, প্রফেসর তুহিন হক এন্ড প্রফেসর তৌফিক যে আসে। আমি আশা করি যে আপনারা তোমরা ইতে ভবিষ্যতেও সব সময় আমাদের এই ওয়েবিনারে থেকে ইউ ক্যান কন্ট্রিবিউট। প্রফেসর আব্দুল সালাম আছে, কথা বলতে পারেন নাই, উনিও কিন্তু জয়েন করে।
সালাম স্যার মনে একটু কথা বলতে চাচ্ছে। সালাম স্যার,
এখন তো কনক্লুডিং রিমার্কস আজান করে গেছে। প্রফেসর মোস্তফা কামাল ফ্রম চিটাগাং, এনআইসিবিটির আমাদের নূর আলমকে দেখছি যে সব সময় আছে। এই যে আমাদের এই গোবিন্দ ফ্রম ময়মনসিংহ, এই যে আমাদের উপস্থিতিটা আমাদেরকে খুব উৎসাহিত করে। আমরা এটা আশা করি যে আমরা এই প্রোগ্রামটা অব্যাহত রাখতে পারবো। আগামী শুক্রবারে আমাদের সাথে আবার জয়েন করবে, এবং আমরা হোপফুলি আমরা দু একজন ডিগনিটারিজ ফ্রম আউটসাইড দি কান্ট্রি আমরা আমাদের গেস্ট, ঠিক প্রেজেন্টার না, গেস্ট হিসাবে আমরা আমাদের প্রোগ্রামের সাথে লিঙ্ক করব। সময় সুবিধা মতো। সবাইকে ধন্যবাদ। এবং যারা নভিস, যাদের জন্য এই প্রোগ্রাম, তাদের আরো একটু বেশি অ্যাক্টিভেটেড হইতে হবে, তাদের আরো কোশ্চেন করতে হবে, সিলি কোশ্চেন, এনি কোশ্চেন, যেমন টেপসি মেপসি এগুলির সম্বন্ধে কোশ্চেন গুলি হয়েছে, এটাতে আমি খুশি হয়েছি। নট দ্যাট কার্সিনয়েড সিনড্রোমে অ্যাবস্টেইনে আরবি কিভাবে মাপা হয়, এটা আই এম নট হ্যাপি। এই অ্যাবস্টেইন নিয়ে কিন্তু আগেও কথা হয়েছে যে অ্যাক্টিলাইজড পোর্শন অফ দি রাইট ভেন্ট্রিকল, দ্যাট ইজ দি মোর ইম্পর্টেন্ট ফর দি প্রগনোসিস অফ দি abstain, not the RV function is not the part of the abstain patient. Anyway, সবাইকে ধন্যবাদ, শুভ বিদায়। সবাই ভালো থাকেন, নিজে সেফ থাকেন, সবাই দোয়া করেন, একজন আরেকজন নিজের জন্য, একজন আরেকজনের জন্য দোয়া করেন। সবাইকে ধন্যবাদ দেই। খোদা হাফেজ।